Good morning, everyone. I'm Dr. Anu, interventional cardiologist at CHI Health, Nebraska Heart in Lincoln. I'd like to thank Dr. Velagapudi and all the course organizers for the opportunity to speak today. My topic is TAVR in women. Are there sex disparities? I don't have any disclosures relevant to this talk. So the learning objectives are to compare sex-related differences on outcomes of TAVR, baseline characteristics of women undergoing TAVR, and post-TAVR complications that are more common in women. So just as a background, I wanted to show this slide where you can clearly appreciate the utilization of surgical aortic valve replacement is much lower in women who are represented in the red bars. But when it comes to TAVR, if you look here at the TVT registry, the number of participants are actually equal, pretty much equal between men and women. So again, coming back to the TVT registry, around 23,000 patients were analyzed between 2011 and 14. Again, the participants are equal amongst men and women. So the baseline characteristics, women are older, they have higher STS scores, and they have lower GFRs and fairly preserved LV systolic function. However, their comorbidities like diabetes, prior CABG, and triple vessel disease, they're all lesser compared to men. So when you look at the procedural aspect, you can see there are key differences in the approach. In women, only 55% underwent transfemoral access, whereas in men, it was much more frequently used, about 65%. Women underwent alternate access much more often. So this slide highlights the differences in imaging findings among women presenting for TAVR. They have smaller aortic annuli, LVOT diameters. They also have less calcium, but more fibrosis in the aortic valve per se. So the pathology is somewhat different. More women were noted to be seen in the paradoxical, low flow, low gradient severe AS. When it came to the left ventricle, they had better LV systolic functions, less myocardial fibrosis, and more pronounced concentric LV remodeling. And then a key difference is the peripheral vasculature. They didn't have a lot of peripheral arterial disease or calcification, but they had smaller iliofemoral luminal diameters, and this becomes very important, as you'll see later on. Now I'll speak a little bit about the key trials. This is from the original partner trial, extreme and high risk TAVR, and you can see in this slide the 30-day clinical outcomes. All-cause mortality, cardiac mortality, rehospitalization, death and stroke were actually equal between men and women. However, the vascular complications, including major bleeding, was much higher in women compared to men. And then when you look, however, at the 1 year unadjusted all-cause mortality and rehospitalization, it was lower in women than men. So big difference here. The mortality was lower in women. When you look at the high-risk cohort for the core valve pivotal trial, again, women were older. They had less comorbidities. However, they were also more frail. And then when you look at this slide, there was actually no difference in mortality at 1 year compared to both groups. Again, same thing in this trial, the major bleeding as well as major vascular complications were much more frequently seen in women. And then now coming to the intermediate risk cohorts, the Partner 2 S3 trial, there was actually no difference in all-cause mortality at 1 year, and there was no difference in death, major stroke, or rehospitalization at 1 year as well. But again, it's the same trend. There's more vascular complications seen in women compared to men. I thought I'd talk a little bit about this study here that was recently published just last year in JACC, the Center Collaboration, which was a global patient-level data set of patients undergoing transfemoral TAVR between 2007 and 18, a large retrospective analysis of 12,381 patients where females actually contributed to about 58%. And in this, you can see during hospitalization, as well as the 30-day follow-up, there was no difference in stroke and mortality. However, the major life-threatening bleeding was again more frequently noted in women. And when you look at this trial, towards the latter half of the trial, there's a greater magnitude in reduction of mortality in men compared to women. However, the stroke rates were similar between both groups. So that's my presentation, and I have 3 questions to discuss. The first question is, vascular complications were seen more in women compared to men because they had greater BMI, they had severe peripheral vascular disease, they had smaller iliofemoral vasculature, or they had calcified tortuous iliac arteries. And the answer is they had smaller iliofemoral vasculature. We'll move to the next question. Which of the following statements is true? Men have lower coronary heights. Women have smaller sinuses. Men have higher transaortic gradients. And fibrotic aortic valve is more commonly seen in men. So the correct answer is women have smaller sinuses. The last question is, in patients with paradoxical low flow, low gradient severe AS, the mean aortic valve gradient is greater than 40. The LV systolic function is less than 50%. The LV stroke volume index is less than 35%. And dobutamine stress echo is helpful. So the answer is left ventricular stroke volume index is less than 35%. So that's my presentation. Thank you so much for your attention. And if you have any questions, please feel free to DM me or call me, email me. Appreciate everyone being here today.